under the name of the late Dr. Adil Ilham. Under his name, we have a competition between young fellows presenting from different countries. We have two presenters from Russia and 4 presenters from Egypt. Are they all available? Oh, so okay, so Kutshay ده ما اعتذر. Okay, so we have 4 competitors from Egypt and 1 from Russia. May I ask the first one? يعني كله recorded presentations. Okay, the first presentation, please. The first presenter is Ammar Muhammad Abdullah.
Systematic review and meat analysis presented by Ammar Muhammad Abdullah, vascular surgery specialist. Introduction. Diabetic foot ulcer are one of the most serious complications in diabetic patients, as they are perhaps the most common cause of diabetes related to hospitalization and may lead to amputation. It has been estimated that diabetes and its comorbidities account for 50% of the lower extremity amputation performed worldwide, and an estimated 85% of all diabetes-related amputation are preceded by foot ulcer. Diabetic foot ulcer is the most common cause of non-traumatic lower extremity amputation associated with diabetes. It's not only cause great physical and mental pain in the patient, but also considerable financial burden on the patient's family and society. It's estimated that the annual risk of developing diabetic foot ulcer in diabetic patients ranges from 90% to 34%. Approximately 40% of the patients with diabetic foot ulcer experience recurrence within 1 year after the ulcer had healed, nearly 60% within 3 years, and 65% within 5 years. Definition and classification of amputation. Lower extremity amputation was defined as partial or total resection of the lower limb through one or more bone structure and perpendicular to the longitudinal axis of the limb. There are 2 types of amputation: major amputation and minor amputation. Reamputation. Reamputation was defined as second lower extremity amputation performed in the same person. The reamputation process that will to this performed at the ipsilateral level or contralateral level. Surgical revision was a stamp not considered as reamputation. Literature search. The database of systematic review were searched for eligible articles published from 2006 and 2019. Inclusion and exclusion criteria. Inclusion criteria was diabetic patient with healed foot ulceration, case control study or cohort study, comparison group between recurrence and non-recurrence, data on the risk factor for recurrence of diabetic foot ulcers reported as odds ratio was 95%, confidence interval 95%. Editorial review, letters, comments are excluded from this meta-analysis. Outcome measures. The primary outcome was reviewing clinical outcome of minor lower extremity amputation in type 2 diabetes. Secondary outcome to be included was to determine the predictor for reulceration and reamputation and mortality. Result. 17 study included in the systematic review and need analysis was a retrospective cohort study published between 2006 and 2018. A total of 3,022 patients was involved, and the mean age ranged from 51.73 to 72.6 years. As we see in this table, the characteristic of the included study according to the number of the patients, male or female, mean age, and average follow-up duration. Result. 7 of 17 studies reported specific data on reulceration. The reulceration ranged from 0% to 75.9%. A total of 573 in liver reulceration were reported after 1,686 transmetatarsal amputation, and the reamputation ranged from 0% to 30%. A total of 116 in liver reamputation were reported after 1,686 transmetatarsal amputation. Hence, we see in this table the characteristic of included study according to the number of the patients who had risk factor, reulceration, and reamputation. Meta-analysis of demographic factor for recurrence of diabetic foot ulcer. The risk factor was age, sex, smoking, BMI, duration of the diabetes, duration of the post-diabetic foot ulcer, frontal ulcer, peripheral arterial disease, diabetic peripheral neuropathy, diabetic nephropathy, diabetic retinopathy, hypertension, total cholesterol. Two studies report relation between age and risk of diabetic foot ulcer recurrence. However, obvious heterogeneity was found between among included studies. Sixth study provide available data for demonstrating relation between gender and diabetic foot ulcer recurrence. The pooled result shows that the male had higher risk of developing diabetic foot ulcer recurrence than female. Five study provide available data on association between smoking and diabetic foot ulcer recurrence. The pooled result shows that the smoking was associated with increased incidence of the diabetic foot ulcer recurrence. 3. Study provide available data on relation between BMI and diabetic foot ulcer recurrence with no highly significant difference. The pooled result of 3 studies shows that the duration of diabetes was associated with increased incidence of diabetic foot ulcer recurrence. 5 study provide acceptable data to analyze the association between risk of diabetic foot ulcer recurrence and peripheral arterial disease. The fixed effect model shows that the patient with diabetic peripheral arterial disease will at significant risk of diabetic foot ulcer recurrence. 2 study provide available data on association between diabetic peripheral neuropathy and diabetic foot ulcer recurrence. However, no significant difference has been found between compound study. 4 study provide available data on association between diabetic neuropathy and diabetic foot ulcer recurrence. However, no significant difference was found between compound study. 3 study provide available data on association between diabetic retinopathy and diabetic foot ulcer recurrence. However, no significant difference has been found. 4 study provide available data on association between hypertension and diabetic foot ulcer recurrence. However, highly significant difference has been found between compound study. Discussion. In our meta-analysis, the risk factor for recurrence of diabetic foot ulcer include male patients smoking, long duration of diabetes, long duration of the post-diabetic foot ulcer, frontal ulcer, peripheral arterial disease, and diabetic peripheral neuropathy. Also, significant differences were found in the age. On the other hand, there is no relation between BMI and recurrence of diabetic foot ulcer. Gender meta-analysis result by and et al. Support our result showing that the risk of diabetic foot ulcer recurrence in male patient was 1.38 higher than the female patient, which was consistent with the result of previous study during et al. Smoking. Separate study, Duplex, Shang et al., Wu et al., Wanjiman et al. Reported that the smoking was not a risk factor for diabetic foot ulcer recurrence. This study were limited in their small sample size, while our result was based on the 5 study. Duration of diabetes. Our meta-analysis also found that with progression of the diabetes, the risk of diabetic foot ulcer recurrence increased, with high statistical significance, which consisted with a study of Yun et al. And Wu et al. But a study conducted by Shang et al. Khalifa found that the duration of diabetes was an independent risk factor for diabetic foot ulcer recurrence. However, the author didn't give any explanation for this negative result. Peripheral arterial disease causes abnormalities in the microcirculation of the foot, resulting in poor blood supply. Hence, the recurrence rate of diabetic foot ulcer in the patient with peripheral arterial disease is high. The duration of the post-diabetic foot ulcer. Our meta-analysis lacked for duration of the post-diabetic foot ulcer as a risk factor for diabetic foot ulcer recurrence. Study shows that the risk of recurrent ulceration in the patient with diabetic foot ulcer more than 2 months at the first visit was 1.93 times higher than that in the patient with diabetic foot ulcer less than 2 months. Conclusion. The result of our meta-analysis shows that the male patients smoking, long duration of diabetes, long duration of post-diabetic foot ulcer, frontal ulcer, peripheral arterial disease, and diabetic peripheral neuropathy with the risk factor for diabetic foot ulcer recurrence. Limitation to this study. There are several limitations to this study. First, some of the research data need to be recalculated and extracted, and there may be error in data conversion. Second, because of the Limitation of the included data, we didn't conduct subgroup analysis and family plans. Some of our results show significant heterogeneity and it's difficult to identify the possible causes. Hence, further research should be conducted to validate our conclusion. Thank you.
Second presenter.
Dear professors and colleagues, I'm Dr. Mohammed Saeed Shahada, vascular surgery specialist at Session3 University. I'm so honored to present my research today among all of you about evaluation of wound healing after angiogram-directed intrapopliteal endovascular angioplasty in critical limb ischemia patients. Allow me to start my presentation by a couple of questions. Did you ever ask yourself after doing tibial angioplasty for critical limb ischemia patient with ischemic foot wound ends with outward beta pulse, is that adequate for the wound to heal? Another question, when you examine infected foot ulcer with good thickness over 130 years, or even double pulse, will the problem be the optimal choice for adequate wound healing? I guess there's established answers for both of those questions, but allow me to go through the presentation, maybe I'll change your mind. What will you do and what will you expect if I told you that patient A, 50 years old female patient, diabetic hypertensive, with infected heel ulcer with good palpable dorsalis pedis pulse? I guess all of us will say that she will go directly for the debridement. And the patient went for direct debridement, and we were expecting healthy granulating ulcer and a total wound healing after a very short period of time. But unfortunately, that's the total of the wound after 1 week of debridement. What will you do and what will you expect if I told you the patient B is a 55 years old male patient, diabetic hypertensive ischemic heart disease, heavy smoker with infected foot ulcer over the dorsum of the foot with tibial disease. The patient went for tibial angioplasty, specifically posterior tibial angioplasty, ends with posterior tibial pulse, followed by the debridement of the wound. And we were expecting healthy granulating foot wound and total wound healing after a very short period of time. But unfortunately, that's the total of the wound after 4 months of treatment. So we sat down and started to ask ourselves, what do we miss? What's wrong with our plan of management that led to those poor results? And we start our research from the basics, from the anatomy. And we found an important definition called angiosome. The angiosome is considered as a three-dimensional anatomical distribution of tissue, which is supplied by a certain type of artery and drained by a certain vein, which evolved consequently. And an important concept which is called angiosome concept, which is intrapopliteal, which is about intrapopliteal endovascular revascularization, guided by angiosome concept of perfusion, had an effective role on the healing of different foot wounds compared to the indirect non-angiosomal concept of perfusion. So, the foot and ankle were divided and classified into 3 regions according to the angiosomal concept, into anterior tibial artery angiosome, posterior tibial artery angiosome, and peroneal artery angiosome as shown in the foot. We completed our research among all the papers which is published through the past decade all over the world about the same concept, the angiosomal concept of treatment. And we found a paper published in Japan 2012, another paper which is published in Finland 2013, another paper which is published in China 2015, another paper which is published in Finland 2017, another paper which is published in Egypt 2018, and finally another paper which is published in USA 2020. All those papers concluded the same conclusion, that complete wound healing rate is better and more effective when target foot lesion receives direct perfusion following angiosomal concept of perfusion. And that led to our study, which is, by the way, published at the Egyptian Journal of Surgery, which is a prospective non-randomized interventional cohort study done at Session3 University. About 40 patients were selected from vascular outpatient clinic between the period of time 2018 to 2020. The aim of our study were evaluation of wound healing and then salvage rate in patients with critical limb ischemia with concurrent foot ulceration, including Gang B, who underwent intrapopliteal balloon angioplasty according to the angiosome concept. And we set our primary endpoint as a complete wound healing and our secondary endpoints as limb salvage rate, amputation case survival rate, mortality rate, and procedure-related complications. We selected our patient according to specific criteria and included in our research patients with critical limb ischemia, Rutherford, grade 5 and 6, palpable repeated pulse, vestibular disease with Bujarnian and non-pulse, a patient with severe acute sepsis, primarily ulcers, non-salvageable limb, renal impairment, and absent repeated pulse were excluded from our research. Our patient went through full detailed assessment, including full detailed clinical history, a clinical examination including general and local vascular examination, full preoperative labs, preoperative general investigation, and preoperative diagnostic investigation for peripheral arterial disease, including ankle brachial index, arterial duplex, and in some cases CT angiography. And we have done investigation for the foot ulcers, including foot X-ray, culture and sensitivity from any active infection. Our procedure were done under local anesthesia, and we have done our ultrasound guided, and we done a preoperative angiography before procedures in order to localize and identify the site of lesion and the target blood vessels, and we end our procedure by post-intervention angiography. Our patients were categorized after the procedure according to the anatomy of the foot wound and the target vessels, which we succeeded to manage into two groups. Group A, a group of patients went for angioplasty according to the angiosomal concept directly related to the wound, and the group B patient who went for angioplasty according to the angiosomal concept indirectly related to the wound. And we have group A included 27 patients, and group B included 13 patients. All the study sample patients showed immediate hemodynamic improvement with technical success proved by intra-procedural angiography and hand radiography. And we found that post-procedural ABI measurements showed marked improvement in both of the study groups compared to the pre-procedural ABI, but without significant difference between the two study groups. Minor amputation in form of toe amputation occurred in 24 patients, while only 16 patients needed surgical requirement. We followed our patient in our outpatient clinic, and the first visit was 1 week after the procedure, and then we followed the patient at interval of time, first month, 6 months, 12 months, and 24 months. All the 40 patients showed sustained hemodynamic improvement during the first month post-procedure, proven by the arterial duplex, and neither surgery-based mortality nor procedure-related mortality occurred in the entire study sample. There is an example of the two groups of the study. The first, indirect angiosomal wound healing rate, represented by this case. This patient went for posterior tibial angioplasty and anticoagulant, as the foot of the wound after 4 months from the procedure, and the total wound healing occurred after 7 months. Another example, that patient went for peroneal angioplasty followed by second toe amputation, and the foot of the wound after 2 weeks from the procedure, another photo for the wound after 3 months, and total wound healing occurred after 6 months. For the other group, direct angiosomal group, that the patient went for anterior tibial angioplasty and big toe amputation, and the photo of the wound after 3 weeks from the procedure, another photo for the wound after 5 weeks from the procedure, and total wound healing occurred after 7 weeks. Another example, that the photo of the patient went for posterior tibial angioplasty followed by the gradient, the photo of the wound after 3 weeks, and the total wound healing occurred after 6 weeks from the procedure. Another example, that patient went for an anterior tibial angioplasty followed by post-toe amputation, and the photo of the wound after 4 weeks, followed by another photo after 6 weeks, and total wound healing occurred after 7 weeks from the procedure. So, 26 of the patients, all included in group A, achieved complete foot wound healing in a very short period of time, in a range 1 to 2 months, compared to 11 patients, which all included in group B, achieved complete wound healing within a longer period of time, within a range 6 to 12 months, which is shown in the graph and highly significant event. So, finally, do I succeed to change your answer to my previous questions, or is it still the same? Are you now convinced to be an angiosom-minded surgeon in your next critical limb ischemia patient? I sincerely hope so. Thanks for your attention.
Third one, Maria Shandina from Russia.
dear colleagues, I'm happy to greet you all. And today I would like to present to you the report about our research that's called Comprehensive Analysis of Secondary Telling Disease after Intravenous Laser Ablation. There is no conflict of interest. In the literature review, it's possible to find guidelines where we describe that matting is one complication after intravenous thermal methods, but there is no data of frequency or risk factors and no references. In this article, intravenous laser ablation found to be statistically significant risk factor of matting in the univariate analysis, but in the multivariate analysis, only 3 risk factors showed an independent association with matting: recurrent epistaxis, prior treatment by sclerotherapy, and hypersensitivity. After intravenous or radiofrequency ablation of Session3, we can notice and we can find sometimes this type of telangiectasias that bigger than usual matting after sclerotherapy. We found it really interesting to explore and to investigate this type of complication after thermal methods. The literature review included stripping, thermal methods, and TNT was with accidental findings or no specific data about frequency or risk factors, or methodology raises too many questions. But there was only one paper. It was a clinical case called secondary telangiectasia after radiofrequency closure of Session3, a result of local outflow of the feeding vein. The authors suppose that blocked outflow of the feeding veins was a reason of telangiectasia. The result was corresponded with Chiva strategy, and it was presented in this book. This information also you can find here. The aim of our study was to determine the percentage of secondary telangiectasias after intravenous laser ablation of Session3 and identify the risk factors for their development. We had a patient who was made isolated laser ablation of Session3 without simultaneous elimination of the tributaries and perforating veins. It was significantly included prospective non-comparative single center study. Our patient was examined, of course, before laser ablation, next day, and 3 months after laser ablation. We did visual and ultrasound examination. And the main thing that we did, it was photo documentation of the lower extremities. Inclusion criteria was varicose veins in great saphenous vein system, reflux in great saphenous vein from saphenofemoral junction to the cone, I or H type of great saphenous vein. We excluded patients with a reflux in small saphenous vein and interstitial saphenous vein through middle type of breakaway vein. We also excluded significant telangiectasias of reticular veins on the inner type before the treatment, with the S type of great saphenous vein with simultaneous sclerotherapy or microthrombectomy of the tributaries, patients with acute deep vein thrombosis and superficial vein thrombosis or post-thrombotic syndrome. With the deep vein aplasia, also excluded arterial insufficiency and skin diseases in the active phase. Before laser ablation, we fixed the patient in age, gender, BMI, C, BCSS, diameter of great saphenous vein 3 centimeters below the saphenofemoral junction and in the middle type. And of course, we did photo documentation of the lower extremities. Comparative analysis of photographs was before and after 3 months after intravenous laser ablation. It was made by 3 independent surgeons who has at least 5 years of working experience. They did separately conducted a comparative analysis of photographs by this scale that you can see on the screen. It consists of 0 points, absence of new telangiectasias, 1 point, the appearance of an insignificant number of telangiectasias, 2 points, new telangiectasias in moderate amount, and 3 points, a large number of new telangiectasias. The benchmark for assessment. Here you can see the pictures that was presenting for the doctors to better understand it. What does it mean 1 point, what does it mean 2 points, and what does it mean 3 points? End results, there was 123 leads in 103 patients. The appearance of secondary telangiectasias on the inner thigh was recorded on 26 limbs, that is 21.1%. That's a big number, right? In 17.9% of cases, these were telangiectasias in a significant amount, while their moderate or large amount was found in 2.4% and 0.8% of extremities. There was complete agreement between 3 doctors. This is really important. And no recognition of brachytenostomy. Here is an example of 1, 2, or 3 points. And as I mentioned, it was complete agreement between 3 doctors. So all of the doctors made almost the same points of each picture. Risk factors. The median age in the group without new telangiectasias was 40 years. In the group with the secondary telangiectasias was 52.5 years. In the right side of the screen, you can see the scale and distribution of the age. And we didn't find any differences in gender, in BMI, C, VCSS, greater penicillin, and diameters of greater penicillin. Discussion. The appearance of secondary telangiectasias on the inner thigh was recorded on 26 limbs, but moderate or large amount was found in only 3.2%. Older age was a risk factor. Here, we mentioned this paper at the beginning, and authors thought that result of telangiectasias was blocked outflow of the feeding veins. Actually, we also found some feeding veins, and probably it was the reason. Our patient was treated by sclerotherapy class, but in the paper that we mentioned before, it was also described as spontaneous resolution. In our study, we investigated in 3 months and haven't found any other follow-up. The conclusion is secondary telangiectasias. Although the inner thigh after the venous laser ablation of greater penicillin developed in 21.1% of the cases. 17.9% in a significant amount, moderate 2.4%, and a large in 0.8%. Older age is a risk factor for the development. Is it an issue? We don't think so, but probably some of you had another opinion. Thank you, dear colleagues, for the attention. Have a good day and enjoy the conference.
Next one is Nihal Mustafa Al-Hussein.
First, thank you for giving me the opportunity to share my paper in such a great event. Today I will talk about role of anti-peak systolic velocity as a hemodynamic predictor following infrainguinal arterial angioplasty. Duplex scan scan is widely used for the assessment of the arterial tree of lower extremities in peripheral arterial disease patients. It is used for assessment before angioplasty and operative intervention. It has comparable accuracy at lower cost compared with CT angiography. Ankle brachial index, the most common physiological parameter used to assess bed severity. It lacks anatomic precision but inaccurately assesses lower extremity perfusion in patients with highly calcified non-compressible tibial arteries. Ankle peak systolic velocity, a new alternative parameter for assessment of degree of peripheral ischemia. It is not affected by vessel calcification. It can be measured in presence of toe gangrene or amputation and during arterial duplex scanning of lower extremities. It can be measured instead of toe brachial index in toe with ulcers, gangrene, or when amputated. ABI and ABSB were never before compared as a predictor of success of angioplasty, and it was the idea of the paper. Study objectives: to compare ABI and ABSB as parameters used to assess angiographic success and clinical success, and to compare between them as a predictor of success after infrainguinal arterial angioplasty. Study design: it is a prospective non-randomized cohort study, and the study plan was accepted by the Ethical Committee of Insurance University Hospital. Inclusion criteria: adult patient with history of CLTI as defined by Rutherford class 4 to 6, any arterial lesion below the level of the common femoral artery with adequate distal runoff. Exclusion criteria: severe foot infection that render limb unsalvageable, patient has previous endovascular or open revascularization, failure of endovascular intervention, presence of aneurysm, patient refusal to participate or absence of written consent, patient known allergy to contrast, heparin, aspirin, or other antithrombotic agents. Outcomes: primary outcome, clinical improvement assessed by Rutherford classification, ABI and ABSB, while secondary outcome was major adverse limb events. Patient evaluation: we took full history, symptoms of CLTI, Rutherford and Fontaine classification, ABI and ABSB pre and post procedure and on follow-up 6 months, duplex scan of the affected limb. Each patient underwent angioplasty with or without stenting, and the details of the procedure were documented. Post-operative medication: all patients were taking antiplatelet, anticoagulation, vasodilators, and statin. What is ABSB? It is the mean of the peak systolic velocities of anterior tibial artery and posterior tibial artery measured at the ankle level. All patients were rested 1 hour before scanning and examined in supine position. It is measured at room temperature. What is technical success? It was defined as successful crossing of the lesion with balloon dilatation resulting in less than 30% residual diameter reduction as assessed by quantitative intra-procedural angiography. Ensure inline flow to the foot. Amputations: minor amputation included digital and ray amputation of the toe, transmetatarsal amputation of the forefoot, less trunk and Schubert amputation of the midfoot, while major amputation included below knee and above knee levels. Most of the patients aged 60 to 70 years, and most of them were males. History was taken from patients as regard smoking, diabetes, obesity, hypertension, ischemic heart disease, and etc. Most of the patients were presented with wrist pain, ulcers, and gangrene. Duplex scan was done to each patient starting from the aorta down to the pedal arch in a through manner, not in segmental manner, trying not to miss any lesions. BSV was taken at proximal, mid, and distal segment of each artery, while ABSV was calculated by the sum of BSV at distal anterior tibial artery plus distal posterior tibial artery divided by 2. Most of the patients have increased ABSV post-operative than pre-operative, while there was minimal or no change in ABI value. ABSV was noticed to be increased on follow-up 6 months than in post-operative and also in post-operative than pre-operative. While ABI value, there was the same value post-operative as pre-operative and also on follow-up 6 months. As regard diabetic patient and non-diabetic patient, there was increase in ABSV post-operative than pre-operative, while ABI there was minimal change in follow-up 6 months than pre-operative. As regard renal and non-renal insufficiency patients, there was increase in the ABSV in follow-up 6 months than post-operative, and in post-operative than in pre-operative, while ABI there was no change in renal insufficiency patients in 6 months follow-up than pre-operative, and there was minimal change in non-renal insufficiency patients. As regards ulcer healing, it was noticed that ulcer healing occurred when ABSV measures 36.5 plus or minus 8. ABSV was showing increase in all presenting symptoms in post-intervention than in pre-intervention and on follow-up 6 months, while ABI showing the same value or minimally change. Here is a scatter plot curve showing that most of the patients showed improvement in their symptoms after 3 to 6 months from intervention. Discussion. In Barado et al., absolute ankle pressure, ABI, and arteriography cannot establish differences from normal values because they cannot predict hemodynamic supply demand. This may be the key reason ABI does not always reliably predict the magnitude of CLI. In Bishara et al., all of the limbs with severe ischemia, ABI less than 0.4 had ABSV less than 25 cm per second, and all limbs with mild to moderate ischemia and the ABI more than 0.4 and less than 1 had ABSV more than 25 cm per second but less than 75 cm per second, while all of the healthy volunteers with no ischemia at all, ABI was more than 1 and patient or volunteers have palpable beta pulses had ABSV more than 75 cm per second. In Venosa et al., there is a strong association between diabetes and medial artery calcification. This condition causes arterial wall stiffness, which results in high pressure ankle and so high ankle brachial index. In Bishara et al., a cut-off value of 35 cm per second, the ABSV found to show high sensitivity and also high specificity and positive predictive value of 90.5% and negative predictive value of 94.2% in predicting non-healing of diabetic foot lesions. Limitations of study: a small number of the limbs studied. Conclusion: ABSV is an alternative arterial flow measure. This fact and simple functional measurement can be valuable addition to duplex examination to objectively quantify vascular status following infrainguinal arterial angioplasty. ABSV could predict healing of CLI patients' lesions with high degree of accuracy. It can be used as alternative parameter to ABI in following up patients after infrainguinal arterial angioplasty, especially in presence of arterial calcification. Thank you.
Last but not least, the fifth presenter is Suhail Nagib.
Good morning, everyone. It's a great honor for me to be with you today, talking about the microwave varicose veins treatment, the early Egyptian experience. I have no disclosures. As you all know, incompetence of the second femoral junction is the most common cause of varicose veins, of about 70%. And NICE guidelines recommend thermal ablation as the first line of treatment of varicose veins. Microwave ablation has all the advantages of radiofrequency ablation and the latest laser fibers. In addition, it doesn't become in contact with the vein wall and act on the water inside the cell. The first case was performed by Professor Whitley in 2019 in London, and our series started only 6 months later. The aim of our study is to prove the safety and efficacy of microwave catheter ablation in treatment of varicose veins. We had 10 patients admitted to Royal Vascular Center in Alexandria, August 1st, 2019 to December 30th, 2019. A prospective study with primary varicose veins C2 to C5 of the great saphenous vein ablated by microwave ablation, duplex guided using ambulant amount of tumescent anesthesia. All patients had clinical examination, duplex examination in informed medical consent. Our primary endpoint was anatomic and clinical success at 1 year follow-up. The secondary endpoint were technical success. We followed the patient 1 day, 1 month, and 1 year post-operative. We excluded patients with history or high risk of DVT, patients with recurrent varicose veins, unable to provide informed consent, less than 18 years, patients with saphenopharynx or refluxing anterior or posterior accessory vein, pregnant females. All our patients were treated by microwave catheter flushed to the saphenofemoral junction with tumescent anesthesia. As you can see, our procedure started with puncture from the great saphenous vein around the knee, and the catheter reached the saphenofemoral junction. Tumescent anesthesia were put, and finally firing of the great saphenous vein with backward withdrawal of the catheter. Our results, the age ranged about 35 years. We had left side dominance of almost 6 patients and bilateral lower limb in 3 patients. Also, our measurement, we had significant decrease in all the measures after 1 month post-operatively with significant p-value less than 0.005. As you see in the figure, the dimension decreased from 66 to 62, from 40 to 34, and lastly from 24 to 22.5. Pre-operative duplex data, the great saphenous vein were from 9 to 14 millimeter with average 11.4, duration of reflux were 0.5 to 0.7 seconds. Absent post-operative reflux were in all patients with all limbs treated 1 day, 1 month, and 1 year post-operative. The time to return to work was around 3 days, with average from 2 to 5 days. Regarding the pain scale, it dropped from 7 to 9 to 1 to 3 in 1 month's follow-up and almost 0 in 1 year follow-up. Post-operative pain was very mild, that was only relieved by mild oral analgesics. VCSS score had significant decrease of p-value 0.01 and with decrease in the values 10.7 to 7.6 post-operative. We had no serious complications, nor minor complication occurred. And before we conclude, we have to know why we should choose microwave. Microwave is an effective method with neither anatomical nor technical recurrence after 1 year. Also, bigger diameter veins can be included to up to 25 millimeters. It is considered more safe as it is working at the lowest temperature of all thermal ablation technology with no forward propagation of thermal energy, malleable catheters that can negotiate the curved anatomy of the veins. Also, it is cost effective as it is a cheap catheter, limited time procedure, minimal immediate post-operative pain, quick recovery, and early comeback to work. So, to conclude, Mr. Chairman, dear professors and colleagues, microwave catheter ablation is a safe and effective method in treatment of varicose veins with expected lower recurrence rates and fewer complications than laser and radiofrequency ablation of the varicose veins. Thanks a lot, and looking forward to see you next year in this great competition and great event. Thanks a lot.
جزيلا لكل الكومبيتيتورز. Just a minute to conclude for the points for the judges and then I will edit it.
لغاية ما لجنتنا I will spend a few minutes for the committee to gather the results, and I'll ask our attendees من فضلكم نقرأ الفاتحة للدكتور عادل إلهام الله يرحمه. I would like to welcome Dr. Maria from Russia. Please, you can unmute yourself, Maria. Hello, Maria. Welcome on board. Hello, Maria, do you hear me? Is there a problem with the voice? Okay, by the way, till Maria can speak to us, I'd like to have a comment. 2 years ago, we have no girls in the final competition. 2 years. Last year, we have only one girl. This year, we have 3 girls. I don't know what will be happen on the next year. Maybe the next year will be only girls in the top 5. Take care, guys. I think the committee no more. I can ask the attendees to come on board. Okay, please, I ask the 4 speakers to come on board. Yes. عشان safety يعني عايزين المالية. Thank you, guys. You did well, and thank you, Maria. I hope you can join us soon. I will ask you if someone has a comment.
Meeting is being recorded.
I'll ask our professors and our fellows if they have a comment for the speaker. Let's start by professors, or let's start. We'll keep professor to the end. Can we ask the attendees? Do you have a comment for first speaker, Dr. Ammar? Yes. I will keep it first for the attendees, not to be influenced by professors. Okay, next speaker, Dr. Mahitab. Okay. Dr. Nihal? Come on, guys. Don't be shy. Okay. Do you have a comment for Maria? Except Dr. Nasser. Okay. Have a comment for Dr. Suhail? Okay. Let us shift to professors. Dr. Magdi, you have a comment for Ammar? He's happy for that.
لا أنا مش على عمار بس على اللي قاعدين. في فرق بين ما تعمل برزنتيشن أو توك أو تشرح لنا رسالة زي ما الجماعة دول اتكلموا دلوقتي. لازم تفرق، أنت مش في الكلية وفي لجنة بتحكم رسالة. أنت بتعمل توك يعني برزنتيشن، كويس؟ فمع الأسف معظم اللي اتقال أنا حاسس إن أنا قاعد رسالة، بناقش رسالة مش بسمع توك. الحاجة التانية في معرفش مين فيهم، أنا مش فاكر بالظبط، صوتك طول البرزنتيشن المونوتونس ده ينيم اللي قاعدين. يعني لازم تعلى في المهم، توطى في الأقل أهمية. حتى ايفن في السلايدز ما تبقاش بيزي زي ما شفنا سلايدز كتير كده. حتى ايفن لو هتجيب جدول، معرفش مين فيكم اللي جاب جدول كبير قوي كده كان مالي تقريبا السكرين. حتى لو هتجيب جدول تعمل شادو على النقطة اللي انت عايز تقولها، وبعدين برضو مش فاكر اسامي، انا بقول توتالة كده يعني تبقى قايل التايتل قدامك مثلا in relation to age. تفتكر اللي قاعد عايز يسمع ايه؟ هي مهمة الايدج ده ولا مش مهم؟ تلاقي ستيتمنت انجلش باراجراف طويل عشان في الاخر اسمع ان هي مش مهمة. لا، اللي قاعد عايز يسمع على طول انت حاطط العنوان عشان سؤال، يبقى ده مهم ولا مش مهم؟ من القصد عايزين سنة تريننج في البرزنتيشن، واللي ما يعرفش افتح النت هتلاقي في اصول للبرزنتيشن. طبعا في الحكم احنا عندنا السكيلز بتاع البرزنتيشن في التقييم ده ما تقدرش تقوله كله، لان احنا شفنا نص الموضوع. النص الثاني الاشخاص اللي واقفين دول نشوفه هو بيتكلم ازاي، يعني كبيرسون يتكلم ازاي. لو انت واقف في وسط ناس تتكلم ازاي. مش هقول حاجات كتير، بس هقول لكم هنت صغيره. لازم تبقى واقف اولا، تبقى فولي دريست وتبقى واثق من نفسك، كأن اللي قاعدين دول ما يعرفوش حاجه في موضوعك ده خالص. ما تعرقش، ما تتهزش في الكلام، ما تقولش الكلام وتعيده، تبقى واخد بالك من الحاجات دي. زائد الكونفيدنس مهم جدا وانت في البرزنتيشن تبقى كونفيدنت. زائد البادي لانجوج بتيجي في حاجات. اول ما واحد نايم ولقى ايدك بتترفع كده هيصحى ويرجع معاك المحاضره تاني. الاي كونتاكت اللي باصص لك، في واحد باصص لك تديله اهتمامه، تبص عليه زي ما هو باصص لك، والكلام يبقى للقعده كلها مش لواحد بعينه. يعني لو الدكتور ناصر السعيد اللي مركز من الاول ما بصش لناصر السعيد على طول، بصه وعيني تقلب على التانيين. زائد حاجات كتير قوي يا ريت من واحنا صغيرين لما نتعلمها نعرف يبقى شكلنا حلو واحنا بنقدم الكلام بره.
Thank you, Professor Magdi. This is very valuable points, and I think all of them has to be in his consideration. Dr. Mantoh, you have a comment?
بسم الله الرحمن الرحيم. الحقيقة الكومنت بتاع الدكتور مجدي بيه كومنت رائع جدا جدا، ونصائح جميلة قوي. الحاجة اللي أنا كنت عاوز أشوف البريزنترز دول واقفين قدامنا، كل واحد بيبريزنت الحاجة بتاعته. مش عاوزين نشوف كلام مكتوب على شاشة وهم بيتكلموا، لا نشوفهم شخصيا وهم بيقولوا. دي نقطة مهمة جدا. وهم أنا كنت تصورت إن هم مش موجودين هنا أساسا، يعني هم باعتين بس الشغل بتاعهم، لكن دول طالما موجودين ما وقفوش ليه وقالوا الكلام ده؟ كنا يهمنا قوي ان احنا نشوفهم شخصيا وهو بيتكلموا. لكن الموضوعات في الحقيقه موضوعات كويسه ومهمه وقالوها لنا كويس يعني الحقيقه، واشكرهم شكرا جزيلا. شكرا.
I'd like to thank Dr. Mamdouh, but I have to explain why I asked every speaker to give his recorded presentation, because from the last year this competition is international, and for sake of internet disorders, we explained and we declared from the start it will be recorded presentation to keep it international and to make it is an equal opportunity for all speakers around the world. Last year we have 3 speakers outside Egypt. This year we have 2 speakers. Fortunately, they were the 2 speakers from Russia, Maria and Dr. Ahmed. Dr. Ahmed has a technical problem too, and he couldn't make his recording presentation. That's why, for equality and giving the same opportunity for guys to join the competition along the universe, we make it recorded presentation. Thank you, Dr. Mamdouh.
I'm so sorry. I'm happy to greet all the people, all the organizers, and I would like to thank you for organizing such a huge and important event. And good luck in the future in the conference. Thank you so much. I'm sorry I had technical problems with the microphone.
Thank you, Maria. I think you are in Pittsburgh.
Sorry?
What's your city? What you live in Russia?
I'm from Chelyabinsk.
Yeah, with Dennis. Yeah, you work with Dennis, yes?
Yes, yes.
Great. I think you both can join us next year. Please mark your calendar. Next year it will be on October 13th to 15th. And I invite you both and all colleagues from Russia. Thank you, Maria, and we all enjoyed your presentation. Good luck. And maybe you are the winner. Please join us tomorrow to know who is the winner.
Okay, thank you.
Thank you.
Okay.
Thank you, Maria. Professor Mustafa, you have a comment?
انا لو ليا كومنت، طبعا انا موافق على اللي قاله الدكتور مجدي والدكتور ممدوح، وبشكر الدكتور ايمن فعلا على اتاحه الفرصه للشباب ان هم يقدموا نفسهم ويعبروا عن نفسهم. فانا مبسوط جدا بالكومبيتيشنز بين اليانج فيلوز، ولكن انا كنت معترض فعلا في الاول على انها تبقى بري ريكوردد، يعني لان الانتر اكشن مع البريزنتر والتفاعل معاه وهو واقف قدامنا بيفرق كتير، وبيديله هو الجاتس ان هو بعد كده يقدر يقدم نفسه ويتحاور وياخد الجرأة مع الناس اللي قدامه الاودينس يعني.
ان شاء الله السنه الجايه.
لكن انا موافق طبعا
السنه الجايه ان شاء الله هنعمل حسابنا، وان شاء الله تكون الظروف احسن ان احنا نعمل انفيتيشن لكل السبيكرز even those from outside Egypt to be here with us in Alexandria and give their oral presentation.
لكن انا موافقك طالما في حد هيبقى من بره ومش هيقدر يجي، يبقى عشان برضو يبقى الناس كلها سواسيه، يبقى كلها ريكوردد برزنتيشنز يعني. الناس كلها اعتقد ان دي رسائلهم الا انت فده المفروض ان هو يديهم فرصه احسن ان هم يبقوا حافظين الموضوع وعارفينه ويتكلموا بطلاقه اكثر على مواضيع رسائلهم، ويكونوا يقدروا يعبروا عن نفسهم احسن يعني. الناس كلها كويسه والدرجات متقاربه جدا 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 اللي احنا مش هنقولها دلوقتي، ولكن انا بحييهم كلهم وبحيي الدكتور ايمن على اتاحه الفرصه للناس كلها. شكرا جزيلا.
Thank you, Professor Mustafa. Dr. Ali, your final comment.
لا فاينل كومنت الحقيقه انا ما عنديش كومنت الحقيقه يعني بقى يعني ما شاء الله الاساتذه الافاضل غطوا كل المواضيع يعني كويس كده. شكرا يا ايمن كتر خيرك مجهود طيب ربنا يكرمك يا رب يعني.
Thank you, sir. Thank you for you all. Thank you, guys. Enjoy the rest of the day. Now we reach our end of our session and our day. We promise tomorrow will be a very nice day. We start at 2 p.m. We have 3 sessions and 1 memorial lecture. Please join us tomorrow early and reserve your seat. Thank you and have the rest of the day. Goodbye.